Welcome to the 2025 Value-Based Healthcare Forum session on artificial intelligence and value-based care. My name is Gina Greenwood. I chair the cybersecurity and data breach response practice at Nelson Mullins Law Firm. I specialize in healthcare regulatory operations, healthcare privacy security, and the integrity of data, and data breach preparedness, response, and legal defense. I am very honored today to have a wonderful panel of distinguished panelists in AI, healthcare, and the value-based space. Our first panelist is David Derrick. David is a true guru in technology with over 100 patents in his name or associated with his name. David developed several technology companies throughout the 2000s, including RemoteMDx, a company that focuses on senior care technologies, Tracker Group, Secure Alert, which is one of the earlier developments of GPS tracking technologies. I'm thankful for that one as a teen mother. Active Care, a company that remotely monitors diabetes, providing innovative care engagement models, which led to significant healthcare savings cost outcomes. David is currently the majority owner and CEO of a company called Health Endeavors, as he's going to tell us a lot about Health Endeavors, and a new friend that he's developed named Alex. So we're going to hear a lot about Alex today. He's going to explain all this during his presentation, but it is a point of care solution that aligns providers and patients in this new AI value-based world. All right, in our second panelist, we have Alan Aussenbaugh. Alan started his career as a healthcare auditor and a revenue cycle consultant with two different Big Four accounting firms, PricewaterhouseCoopers and Ernst & Young. And he's assisted with mergers and acquisitions of healthcare systems through the years. Alan currently manages AI value-based entity systems, which coordinate patient care between primary care, specialists, and facilities, working to enhance patient care and healthcare systems sustainability. And finally, I'm privileged to introduce my partner in crime, my law partner, practicing with me at Nelson Mullins Law Firm, Mallory Atchison. Mallory co-chairs the Global Privacy and Security Group and brings with her a deep expertise in the intersection of artificial intelligence, regulatory compliance, privacy, and transactional matters. If you haven't had an opportunity to get to know Mallory, she is an amazing attorney. Mallory has advised Fortune 100 companies across industries on navigating complex data challenges with a focus on sensitive data types. Mallory holds multiple certifications in privacy, including the CIPP Europe, CIPM, and she's also a fellow in information privacy. She's an active thought leader in both AI and she was named an AI Visionary of 2022, honoring her role as an early developer of AI, the future of AI in legal and compliance contexts. Mallory's practice spans global privacy regimes, and she's in emerging AI-specific frameworks. She regularly helps clients operationalize compliance, assess risk in AI development, negotiate contracts, and integrate privacy into product design and procurement. And with that, let's launch into hearing from some of these amazing professionals. But before we do that, I want to remind everyone that if you are seeking CLE credit, you will need to know the affirmation code for this session is artificial, all caps. The affirmation code for this session is artificial to receive your credit for your CLE. Attorneys participating in this session must record the following affirmation code to get the CLE credit. Each session will have a unique affirmation code. Following this event, a CLE request survey will be distributed. To qualify for CLE reporting, participating attorneys must enter the affirmation code specific to each session that they participate in to verify active participation in the session, meeting multiple jurisdictional requirements for attendance. So again, your affirmation code for this session, the AI session, is artificial. All right, and with that, I'm going to turn this over to our distinguished panelists so that they can begin talking.
Whoops. Back. Gina, thank you. Thank you for the intro. And I will say this has been a fabulous conference. Nelson Mullins has really outdone themselves, in my opinion. They're a fabulous law firm, and I use them for almost everything we do. So thank you to Nelson Mullins. I've been very impressed with the panels and the panelists. Juliet Price, in her opening remarks just hit on some core things that we'll want to talk about today, and especially as it relates to what I'm trying to do at Health Endeavors. So she made a comment, and that comment was, we've lost our imagination, and we need to dream again. Well, several years ago, I bought Health Endeavors for the purpose of dreaming again and bringing back imagination to healthcare. I do believe healthcare is going to undergo a great transformation, and part of it is going to be data driven, as was talked about earlier today. So the topic today is artificial intelligence in value-based care. And apropos to that, I think one of the problems that we have as we start talking about this subject, about AI and about value-based care, we tend to overcomplicate it. And I'm not saying that we shouldn't overcomplicate it, because they are complicated subjects. But AI, we kind of put it in a black box and think, okay, well, AI does this, AI does that, et cetera. And I think it's important for us to understand what AI is for just a moment, and then talk about what value-based care is at its roots. So AI is not sentient. We say artificial intelligence. It's not intelligent. It's not sentient. What it is large language models using machine learning and algorithms that allow things to be done that a human has done first, but can do obviously much quicker than a human can. And so I think it's important to understand that premise. Secondly, well, let's talk about what AI can actually do really well. AI is good at many tasks that feel intelligent. I'm going to underline feel just right now. It's great at many tasks that are hard for humans to do. It may take us a month to do something that AI can do in seconds. It's especially good at finding patterns in large data sets. I think, Alan, you're going to be talking about that just a little bit. But what I would like to emphasize, especially in healthcare, that AI can augment and support expert human care, but not replace it. I think we get this impression that that we're going to be replacing the doctor or clinicians. We are not, and I want to underline that. AI is not in a position to do that. In fact, I even like to rename AI. Instead of having the acronym AI, meaning artificial intelligence, I like to say the acronym should be augmented intelligence, so that we're actually trying to help humans do their jobs better, and maybe, as we talk further about this, at the top of their licenses. So that's AI in a shell. Now, let's do the same thing with value-based care. Value-based care has its own black box, and as you have heard today from the different panels, it's a complex black box. But if we were to strip it down to what value-based care really is, it's not as difficult as what we think. Value-based care is really defined as improving the patient's health and at lower costs. That is the premise of value-based care at the end of the day. So one of the things, as we talk about value-based care and things of that sort, and even though I've oversimplified it, Health Endeavors is very much a SME in value-based care. We do quality reporting, have a quality reporting analytics platform, a data analytics platform. We are ONC certified, and we are a qualified registry. And as such, we are able to really help our client partners navigate this complex area of value-based care. In fact, in 2024, our client partners, 97% of them, achieved MSSP savings, and the gross amount of the savings was just under $500 million. So pretty impressive. And the distributed savings was approximately $261 million. So we're proud of what we are from that perspective. But what we're trying to do is that's not enough. And so we have been at Health Endeavors putting our brains together how AI can actually help take us to that next level of performance in value-based care. And as we've done that, one of the things that we've come up with that we feel very strongly about is that artificial intelligence is ideal for patient engagement. Now, Juliet mentioned in her opening statements that about wearables and things of that sort. The public, the general population, is really beginning to get in gear to manage their health. And it's important for the healthcare systems to start getting on board with that and helping them and getting aligned with their patients. And so one of the things that I have, from my 30 years of experience in the healthcare arena, that I have been developing is that care managers really are effectual in lowering costs and being able to improve the quality of care or the quality of the life of the patient. And so several years ago, one of my entities actually participated in a care management study. And what is care management? That's where a care team is actually assigned to an individual and help them manage their chronic illness or their care as they are on a care continuum. So in this particular study, it was in a diabetic population. And the average claim costs in that diabetic population was $13,700. With good care management, we were able to lower that by $2,400 or 18% in the claims costs. That was significant. But not only did we lower claims costs, but their A1C levels dropped significantly. So it was reaching that goal of what value-based care is trying to do. And where did it save? By the way, this was published in U.S. Endocrinology in a peer-reviewed study. And where did the savings come from? A 26% drop in ER visits, a 29% drop in outpatient stays, a 35% drop in inpatient stays, and a 23% drop in urgent care. Ironically, as patients become more engaged with their health, they actually seek advice. And so primary care visits actually went up by 10%. So it gives you kind of an idea of what can happen when you have good care management. There's a problem, however, with care management, and that is good care management will reduce costs and aligns the patient with the care team. But the problem is one care manager can only effectively handle 175 patients. What does that mean? That if you have a large provider system, you have to have an army of care managers in order to fulfill this mandate. And so it just isn't scalable. Well, this is where the revolution of AI comes in. AI can make things like this totally scalable. So let me go through what an AI-driven virtual care manager could do. Follow up with patients on their medication adherence. They can be explained as relates to what their chronic illness is and how to better manage it. They can collect RPM data on blood pressure and A1C levels. can answer any questions that as relates to their care plan or even how they're reimbursed, can schedule follow-up and primary care visits. And lastly, where necessary, it can escalate in real time to clinicians, human clinicians. Now, what does that do to the system? One of the other points that was presented by Juliet earlier on was the fact that you've got provider burnout. Well, the main problem with provider burnout is providers are not practicing at the top of their license. They're almost at the bottom of their license. So in order for, if we can get them where these instances are escalated to them and so that they can practice at the top of their licenses, this helps reduce provider burnout. Okay, so I've made my case as relates to why I believe virtual care management is so important. But now let's talk about AI itself and some of the problems that you have in dealing with AI. AI is only as good as the data you put into it. If you have bad data, you're going to have bad results. If you've got good data, you're going to have good results. And so it's extremely important that you control how the data that you're using. And the issue in today's world, if you use open source data, which means just going to the internet and grabbing it, there's as much misinformation as there is clinical approved information. And so you're going to get this misalignment between the provider and the patient. And you get also what we call hallucinogenic results. And this is an example. This particular slide is a slide that was actually created by one of our advisors, Dr. Tyler Jarvis, who heads AI at Brigham Young University, wrote the book on AI, and he asked his chatbot to give him some examples of people shaking hands. Well, if you look at this in a little bit of detail, yes, it fulfilled people shaking hands, but you can see it was totally hallucinogenic. You had 6 fingers, you had 4 hands, you had a whole bunch of things that, because the source code was not contained. So the secret in using AI in healthcare is that you have to have it as a controlled data sources. And if you do that, then your results end up being correct and you can get alignment then between the provider and the patient. And I would propose that patients are hungry for having a guide on their side to be able to align themselves with their PCP. Okay, so let me tell you what we've done at Health Endeavors just for a minute. So in order to we've created a virtual care manager, and that virtual care manager is known as Alex. We're going to introduce you to Alex in just a minute. But to power Alex, we've created OmniView. And OmniView assembles data from a closed loop system. It's not open source. So we have tools called Carebotix that integrates directly into the EMR. And so we've got clinical data from the EMR on that particular patient. What OmniView is creating is a 360-degree digital persona of that patient. And so we have the clinical data from the EMR. We have out-of-network clinical data, which not even the provider has, that can show, because we're a member of TEFCA, that we can bring in if this person went to another out-of-network surgery for his hip or something of that sort, so that we've got all of that clinical data that can be assembled. We have medical claims data, both from CMS and commercial. We have just a whole variety. We have pharmacy data, we have lab data, we have VRDC data from CMS, and in addition to that, we actually bring in consumer data on the individual. We know what language he speaks. We know where he lives and the particulars of that, and so that we can gear our interactions with Alex's interaction with the patient in a way that is meaningful and helpful to the patient. So that gives you kind of an idea of OmniView. Then what we have done, in order to make sure that we have the guardrails of not having any hallucinogenic event, we have purchased from, or finalizing the purchase from Providence Health, a $40 billion system in the Northwest, their medical library called MedPearl. And it's a beautiful library that they have spent a great deal of time and effort on. And we use that medical library to create the guardrails so that, once again, we cannot have an AI event that is hallucinogenic. And all of this comes to bear to create a virtual AI agent that is, in my opinion, is going to be fabulous. So with that, I mentioned to Gina, we've gone through this conversation just a little bit. And last Friday, as I was talking to Gina, Gina says, well, I want to meet Alex. So Gina, I introduce you to Alex. Would you just talk a little bit about your situation?
Yes. So I'm a healthcare regulatory lawyer by trade. I'm a privacy lawyer, I'm a security lawyer, and I'm a skeptic.
That's needless to say, you are a skeptic, that's for sure.
I risk manage for a living. And so I was like, there's no way I'm moderating a panel without seeing this product demoed in real life. And so Friday afternoon, we got on the phone. This was totally unscripted, so I'm going to sound like a complete buffoon in this scenario because I know nothing about diabetes. I have never had to measure my insulin levels or anything like that. So, but I wanted to see kind of how the persona of Alex would pivot if I was kind of throwing stuff at him. And I don't know that I did the best job of even doing that, but I was very impressed with the humanness of it. And we can talk more about, the guidance that he was given, whether or not how that can be customizable in a regulatory environment. But it was very interesting to me. And so we're going to ask our team to gear up Alex and let you hear from him and help us monitor so that we know when Alex is finished talking. So with that.
All right. So once again, this is, we record all of our Alex's conversations. And so this is the recording of Gina meeting Alex.
Hello, I'm Alex from Dr. Jones's office. How are you today?
I'm great. How are you, Alex?
I'm doing well, thank you. I'm glad to hear you're doing great. I wanted to follow up with you today to check in on how you're managing your blood sugar. Are you still using the CGM that Dr. Jones prescribed?
Actually, I decided that I probably shouldn't do that. I was having some side effects from that. And so I wanted to talk to Dr. Jones about that a little bit.
I understand. And I'm sorry to hear about the side effects. It's important to feel comfortable with your treatment plan. In the meantime, are you using a finger stick glucometer to monitor your blood sugar instead? If so, could you share what your fasting blood sugar has been in the mornings and your average during the day?
Well, my blood sugar is, I don't really remember because I'll have to go back and look, but I can get you that information maybe in an email. Would that work?
That sounds like a great plan. Emailing me those details would be helpful. Thanks for taking the time to do that. While we're chatting, I wanted to check in on how you're doing with your diet and activity levels since Dr. Jones emphasized working on portions and increasing movement. How's that going for you?
Well, I'm walking at least 1 mile a day, and I'm trying to cut back on my carbs. But back to the side effects a little bit. I've really been experiencing some significant cramping in my stomach area, and I've been having some chest pain. So I was just wanted to point that out.
Thank you for sharing that with me. Cramping and chest pains are definitely something we need to address right away. It's important not to ignore those symptoms. I strongly recommend scheduling a telehealth visit or heading to urgent care to get checked out as soon as possible. I can help you set up an appointment with Dr. Jones if you prefer that. Let me know how you'd like to proceed.
I think I probably need to get in with Dr. Jones very quickly. If you don't mind, if you could set up an appointment, that would be great.
Absolutely. I'd be happy to help you with scheduling an appointment with Dr. Jones. Could you please provide your full name and date of birth so I can access your record and find the earliest available time for you? Okay.
So interesting, huh? My gut reaction about Alex was, wow, that's pretty human-like. The intelligence that he showed, or the augmentation that he showed for that care coordination event, was pretty amazing. I just had a couple of questions for you. It's the healthcare regulatory risk manager perspective. So, historically, we healthcare regulatory lawyers, we set up patient portals. We talk about emails between healthcare providers, which I could totally see how an Alex could reduce that administrative task that an office staff person and or a physician has to deal with every day. But, like when you start talking about chest pains and he's sending you to a doctor or to a I think it was a telehealth application or to urgent care, if a healthcare entity wanted to say, value-based healthcare aside, I realize emergency room visits are expensive, if they wanted to say, no, pick up the phone, call 911, and go to the ED, is that a customizable thing?
Absolutely.
Or how does that work?
Yeah. All of this is customizable.
Yeah.
And so it really just depends upon the provider system and what they really want to have happen. Okay. And of course, with your review, Gina, as legal counsel on such a thing.
Well, and the other question I asked him was, are there any indicators built in around mental health? Like if you, obviously, we can all tell when we're talking to someone that has mental health issues, even without an MD behind our name. And are there, as far as the augmentation versus the artificial intelligence, how does that play out? If you start to, if it indicates that there's something going on here mentally that might require a little bit more of an elevated level of care.
Well, and once again, these are all things we need to work through and work on. But once it is triggered, then what can happen is that phone call or whatever it might be would be passed off to a human who can then take it from there.
Right. So this is definitely in the beta stages, the development stages, so it's only going to get better. But I was very impressed with the personal touch that it gave. It was an interesting, there were times that I'm like, is this really a bot that I'm talking to? I mean, is this a person behind this? I'm not real sure. So congratulations on the technology, and we look forward to that. I could totally see, daily care coordination type, calling a patient, have you taken your medication today? 90-year-old lady
Right.
patient, have you taken, or did you take the blue and white pill? Do you need a, prescription refill? So I think there's some very interesting models that can come out of this. It's exciting in the world of healthcare.
And understand, even on that particular point, we know whether the medication was picked up at the pharmacy.
Exactly.
So, yeah.
It's great. Wonderful.
Perfect.
All right. Is there anything else you wanted to add, and are we ready to pass?
I think this gives everyone kind of a taste of the future. This is actually happening. AI is here to stay, whether you like it or not. AI is here, and it'll transform healthcare. I'll guarantee that to you. And even though we're trying to maneuver through the legal side and a variety of other sides, it's here, and I would embrace it. I would encourage you to embrace it.
All right, and with that, I think if you would pass the baton, and let's hear from Alan for a little bit.
Well, this has been a fascinating experience, as David was saying, and we're all working out in our island. And what's going to be really interesting is I hadn't heard David's discussion before, and my points, my numbers come very close to David's, and I can reconcile even where we do have differences, but it's going to basically affirm a lot of what David said. So the one thing I really want people to understand is that the VBE, at the end of the day, and we're working at it from a little bit different angle, but the VBE can provide and I'm working at it from a micro network. So generally I'm taking 15 primary care to 20 primary care practices, putting together either a medical facility that's in existence or one that we're building, and then I'm wrapping it around the specialists. So we're all working as a cohesive group, and we're using AI to provide care. And so, for instance, when David was talking earlier about, and he's right about the scalability, where he was talking around it would take one medical provider, they could handle about 175 patients under this WellCare system. Well, using AI, we're now up to around 350. We're getting close to doubling the productivity using AI is a real case example. So our doctors, our specialists, and our hospitals right now, without the VBE and the AI, are in a lot of cases in fairly dire positions. For instance, 70% of independent primary care doctors that wanted to stay on their own are now in either some sort of either a private equity system or they're in a hospital system because they just couldn't make it on their own, just providing acute care. Walmart tried to get into acute care and they failed. They're closing all of their practices. Walgreens, CVS, United through Optum, they're all scaling back. So unless we bring some of these things to bear, I'm really concerned about our medical community. Our specialists, they're seeing their CPT fees, what they get paid to do a surgery, they're seeing those numbers either stagnant or not keeping up with inflation, and in some cases actually going down. So, and then the hospital, less than 50% of hospitals are profitable. So all of these things are what Nelson Mullins has brought together a group. We're all kind of, this is what's so exciting about this. We're all kind of going through our individual paths, and it's been really nice to sit here and be able to start sharing, okay, what's working for you, what's not. We may be competitors in some points, but we're all trying to build a better system. And so at the end of the day, what our system primarily does is two things. It takes providers, and we start building a baseline through doing annual wellness visits. We start doing, and a lot of things that David was talking about, we're doing remote monitoring, and we're providing chronic care management. And we use providers as the forefront of that, but we can't make that system work without the augmentation of intelligence. I'm gonna steal that from you.
You got it.
But that's exactly what it is we use AI in our case. Right now, we're using it in an app format. We don't have the voice like David has, but our app sends out a notification to the patients, and we have between the AI software app and by using remote devices similar to what David's using, we're tracking blood pressure, we're tracking glucose. And one of the things I've added is I track weight. If I have a sudden increase in weight and I've got fluid accumulating in the body, well, that's another reason, things that we want to check. So we're using AI to track all of that and then get that information back to the provider to contact them. And so, but that first, the patients they're getting queried to perform these things. And then what happens is also if they're having an issue, for instance, if they're having a pain issue or something of that nature, then they get on the app and they notify the AI system, which again then sends that to the proper medical provider. So that's what's important in what we do. And so at the end of the day, now we're going to talk a few of the numbers that are similar to what David's finding, but by using like on the provider side, using the ultrasound and using our different diagnostic systems, we're finding early detection of diseases, and the CDC will validate that if we can find cancer in an early stage, find other major illnesses in a early stage, we can reduce medical costs by almost 50% in that. Now, in David's case, his focus has been on the diabetes when I was watching that. And we're at the primary care level, we're dealing with a much broader range of, we're following 26 different chronic care conditions. And so a lot of times our goal is the patient contacts us. And then a lot of times in the past, they just went to the emergency room. And we found about 40% of the time that we can either get them back into the clinic or we can call in a prescription. All of that we provide on a 24/7 basis. And so their primary care doctor used to just be open, from 8 to 5. And now using AI, now we're under 24/7 continuous monitoring. So if we can provide those things and also like when our patients have surgery, we've referred them to the specialist, they've had surgical care. Well, then post-surgical care, they're on that app again. If they're having pain and rather they used to just go to the ER, again, about 40% of the time we can take care of that without them going to the ER. And then finally on the hospital side, when our patients do need to go to the ER, our post follow-up using AI, again, if there's an issue, we monitor that, and about 40% of the time, we can prevent readmittance, which is extremely important to the hospital. And then finally, on the hospital side, on the OR, by using our software and scrubbing data and what have you, in 2 different hospitals, we were able to reduce the OR time. We were able to increase efficiency. So, for instance, if we had a joint case and somebody was having an implant on, either their knee or their shoulder or their hip, we've reduced that operational time by about 50%. And so then that patient also, then they're not under anesthesia for that amount of time. We've also been able to reduce the cost of the implants. So we've been able to, at the end of the day, we've been able to take a study and reduce and make a hospital profitable. And so I'm going to kind of wrap this up and turn it over to you because we're getting there. But at the end of the day, what we've been able to do is we're allowing surgeons that want to stay independent, primary care physicians that want to stay independent, do so under a VBE umbrella. And we've been able at the primary care level, we've been able to make them financially sustainable. The surgeons, we've been able to make them financially stable, and the hospitals. And we've done that by reducing cost and increasing efficiencies. And we can't do that without AI. So at the end of the day, if we don't embrace this technology, we're all going to suffer. And as we saw with that conversation, you felt comfortable, and we're finding that our patients, now that they feel control of their health care, they don't mind talking either to a voice or responding on an app that's driven by AI, and they don't actually they're fine with it. And you would think that would have been a point of concern, but it's not. But anyway, I appreciate your time, and I'll turn it over to Mallory then.
the clicker.
Oh, you would like it.
Thank you.
All right, so let's talk about some guardrails, Mallory, and from the legal and compliance perspective, talk to us about that a little bit.
Yeah, so I'm here to kind of give the lay of the land of where AI regulations have come into play now. I do think it's important, I know you talked a little bit about it, but to set the stage on what do I mean when I say AI? Because my biggest pet peeve is when a contract comes across my desk and it defines AI as just anything that a computer touched, right? And then bans that outright. So let's talk about that a little bit. If you watch the news, you might have been thinking that AI was invented just a couple of Novembers ago when ChatGPT came out, but that's just not true. We have been using AI in our lives, in consumer products, in law, and in healthcare even for decades. There is AI that you would commonly know as machine learning, predictive coding, right? You're putting classifications on things to try to rank things and classify them. What came about a few Novembers ago with the emergence of kind of ChatGPT is what we call generative AI. And that is what you were alluding to, where it is an AI model that is trained on what's called a large language model. So a massive amount of data points, of data sets that train that model to then help it to produce some sort of content, whether that's a voice, whether that's text, whether that's code or an image. That's what's really taken the world by storm. And even that has been evolving so much. GPT, when it first came out, was a totally different version. It keeps upping, right? From 3 to 4 to 5. They add on new features and functionalities and guardrails. And so even in the last 2 years since we've seen the kind of big boom of this, we've seen the technology evolve so much. And part of that has really made just this widespread adoption in life in general, right? But also in healthcare, in law, in lots of different practices. And so since we've seen this big boom of emerging adoption of this, we've seen the law try to catch up and vendors trying to catch up, right? It used to be when it first came out, I would talk to a vendor and try to negotiate something in for a client who wanted to use it, right? Like a big company, and they would be like, go to our public-facing website, here's our terms and conditions that say don't put any confidential information, don't put any personal health information, any personal information. We have people review it. That's just what it is. But then they started realizing they weren't going to get the sophisticated clients, right? When you have sophisticated clients in regulatory spaces, then they started realizing that they needed to offer these, what you referred to as kind of closed loop systems. And so we still have a lot of the same issues that we had when it all first emerged, but those are changing and evolving, right? We have IP protection issues. Everybody's worried about, well, what if the output contains copyright? Is that infringing? Who's the infringer? How can I own it? We've recently seen some of that litigation come to head in the form of licensing, right? Now these models are going out and they're licensing some of the data that comes to it. Privacy is a big thing. Again, at first, it was kind of that open source model. It's trained on everything. And now we've seen a shift in vendors who understand that they need to comply with privacy and security guidelines, right? That they need to have the option to have something behind a firewall, right? Or an API that goes in, but it doesn't train on the rest of the data. And it's allowed vendors to create these bespoke models that are really tailored to healthcare, to law, to whatever it is. And I couldn't agree with you more that any AI model is as good as the data that it's trained on. Not all data is created equal. And if you have a model that isn't trained to what you need it to be trained on, your AI is not going to be the same. We've still got bias testing questions. We've still got audit questions. So that comes with all these guardrails and things that we're going to talk about. Now, we do this conference yearly, and I don't know if anybody got to watch last year's, but my colleagues Trish Marcus and Darren Skiles did a great presentation on AI. And in that, one of the themes was, hey, we're kind of in the wild, wild west, right? There's not a lot of laws that are covering it. And so they did an amazing job talking about historical laws and how those were going to be interpreted to apply to this new technology, right? HIPAA. And I think it's on YouTube, so I encourage everybody to go back and look at it if you haven't. But that's not the case anymore. When I went to go look at trackers, in last year, we had over 250 AI-related healthcare bills that were introduced. So we do still have a lot of the stuff that is the same questions. And how do we interpret these old things? But due to a lot of different factors and a lack of one federal AI privacy law, and I don't think we'll really see that regulation, What we have now in the United States is a patchwork of privacy laws, a patchwork of AI laws, a patchwork of healthcare laws that all integrate together to try to figure out what it is that you need to comply with. And that's made it extremely important to have compliance be the tail that is wagging the dog. I wanted to go through a couple of examples of these. We do have really specific state laws that are going towards AI in healthcare space. We have a lot of them emerging that have to do with chatbots, in needing to have disclosures if somebody is interacting with a chatbot that might be doing a certain thing, in making sure that your chatbots aren't alluding to or insinuating that they are a licensed healthcare professional, right? We also have lots of laws that are popping up around mental health. You talked about that a little bit, Gina, right? If there are guardrails in place, if somebody brings up something about suicidal ideation, right? How not to respond to that, how to properly give guidance and direct that to somebody. So we're seeing a lot in the state AI laws. We are also seeing it in federal oversight now, right? CMS came out with an AI playbook where they are emphasizing model explainability, bias mitigation, documentation, and clinical oversight. They, to your point, emphasize it is not to replace clinical judgment, but to support it. We also have software as a medical device, which is being regulated by the FDA and expands into generative AI. So there are ongoing monitoring with laws with that, transparent documentation with that. We also have the White House executive orders that are differing on various things. And we've got active FTC enforcement, right? We've had them issue inquiries about chatbots and the potential to speak with minors. We've had them issue inquiries into your marketing materials and how you are marketing your AI services in terms of their accuracy, right? Their lack of hallucinations and how you're backing those up. And we've also seen litigation and settlements that go to not just fines and penalties, but what they call algorithmic disgorgement. So if that data wasn't collected properly, they've gone as far to say you have to delete the entire algorithm. And so that's really made compliance front and center. And in figuring out how do we comply with the patchwork of laws that we have. So what does this mean? To me, we're not saying anymore it's the wild, wild west. Here in the United States, we don't have as much regulation as other industries, right? I mean, other countries, right? We had the EU AI Act that came out first. In true form and fashion, we were a little bit slower, but now we are seeing a pickup in legislation, in past bills. I expect it to continue. And so understanding as a buyer of technology and value-based healthcare, or as a vendor who's creating it, you've got to build this into your design. You've got to have data mapping, understand what data is going in, where it's coming from, be able to keep with, data accuracy, data provenance, make sure that you've got bias testing in place, right? That you're able to audit, that you've got a clear understanding of the contractual responsibilities. I always like to say that in a contract, it's where we lay out the responsibilities, but really it's the partnership that makes everybody be in compliance, right? So it's ongoing monitoring of your vendors. It's having that vendor management program. It's making sure that this technology is augmenting, not replacing, working with your vendors to understand where is the human in the loop? Where can we put that in there? Working to understand NIST and ISO. We were talking about that a little bit earlier. Incident response protocols, how to respond to that, right? And having that shared accountability between all of the parties that are trying to, like you said, just make this system a little bit better. Gina, do you want to talk a little bit about how that pertains to HIPAA and how we could see that?
HIPAA, as we all know, we've dealt with HIPAA for years, and it really provides a floor of privacy, security, and data breach protection for different kinds of data sets. But there are lots of exceptions to HIPAA that you might be able to utilize, if you are using some of these technologies. And I would encourage people that are developing the technologies, as you've already said, it's privacy by design, it's security by design, it's data breach response by design baked into these products from day one. Otherwise, you've missed a really good opportunity. Now, Alan said, but what if that data was already collected before we got in the room? You've got to go back and kind of unscramble that egg and figure out what data sets you have, what data points you have. Figure out what hat under HIPAA that you're wearing. Are you a covered entity or are you a business associate? What are those contracts? Who owns that data? Mallory's already touched on a lot of the stuff. Are we in notice land or are we in authorization land? And what is the difference? What are the unique data sets that are more stringent than HIPAA that are going to require that give patients more rights or restrict the use or confidentiality of data more? Those are not going to be preempted. Part 2 data, alcohol and drug rehab data, we have to always think about those. But there's a lot of opportunity. This is, in some ways, this is nothing new under the sun. We've been doing this for years for big data brokers, trying to figure out where is that line of what you can and cannot do as a business associate or a vendor of a covered entity with data uses, and what is an inappropriate disclosure, what requires a consent or authorization versus you can get by with a notice provision. And it's not to downplay it, what are the ethical constraints around all that? So very interesting things that we're going to be working through. From a data integrity perspective, I would strongly encourage anybody developing an AI model. We have had nightmare situations where, you've got 3 John Smiths or 3 Jill Jones or 3 David Smiths, and how do you know you got the right David Smith? And you start aggregating data and making clinical decisions about that person, that potentially could be life altering, making sure that you've got the data integrity issues taken care of. And then we're going to wrap, but I'm a data breach lawyer by trade as well, so I just can't stop without saying incident response planning. There are going to be inappropriate disclosures, there are going to be inappropriate uses, there are going to be situations where data gets in the wrong hand, a spreadsheet of data goes to the wrong party. And do you have the appropriate responses in place? Are you complying with the various security policies and procedures that are out there that might apply to that data set? Business continuity plans. All those sort of things are going to be very critical. Business impact analysis and incident response planning is going to all be critical, and insurance.
Yeah.
And with that,
I wanted to point out one thing that I put on the screen really fast with our minute left. So a couple of my colleagues, Trish Marcus, Jason Epstein, and myself, tried to put our collective minds together to really try to distill what this very complicated, a whole channel of thought would go into in a pretty, maybe a lot of text on a flow chart here, but in thinking through all of the different questions you have to ask yourself as you're going to use AI in healthcare, right? And they go to a lot of the points. Is it open source? Where's your data? What rights do you have? What are you trying to get with the output of the data? Did you get your consents or your authorizations for the input of the data? You've got FDA considerations, ONC considerations, HIPAA considerations, privacy considerations. And so all of that goes into just working collaboratively together to make sure that we understand how we can move this forward.
thank you so much to all of our panelists today. What a distinguished group, and it's just been an honor to moderate this panel with you. I know that the audience will probably have follow-up questions, so I would encourage them to email you outside the session. But thank you for joining us today for AI and value-based healthcare.